Good day, everyone. Good day, everyone. We welcome you to this Zoom conference organized by Nigerian stakeholders involved in the collaboration of the launch of the Global Strategy for Elimination of Cervical Cancer. My name is Dr. Folike Sarimiye, and here with me is Dr. Samuel Ekundayo, who will be moderating this epic and historic meeting.
Good day also. This activity started yesterday with the lighting of monuments and landmarks globally. And today we are gathering to discuss the way forward in achieving the 90-70-90 target by WHO.
So we have here with us stakeholders and representatives that are all involved in the noble cause to end cervical cancer.
So we ask that you feel free to contribute, give comments, and also ask questions. Before we go ahead in this meeting, I will ask that we take the first stanza of the national anthem of Nigeria. Thank you.
Mute your microphone. Mute.
Patrons, Nigeria's call holy to serve our fatherland with love and strength and faith. The labor of our heroes past shall never be in vain. To serve with heart and mind, one nation, peace and unity.
God bless Nigeria. We would like to go on and introduce the chairman of this meeting for his opening remarks. However, before he does that, I would like him, Dr. Samuel Ekundayo, to read the citation.
Thank you, Dr. Folike Sarimiye. I'm privileged this morning to read the citation of our able father and a great man that has impacted health in this country, Professor Isaac Folorunsho Adewale. Professor Isaac Folorunsho Adewale is a professor of obstetrics and gynecology, College of Medicine, University of Ibadan, Nigeria. He is a gynecologist, the immediate past Minister of Health, Nigeria, former Vice Chancellor of the Premier University of Nigeria, University of Ibadan, Nigeria, and former President of Africa Organization for Research and Training in Cancer. Professor Isaac had sat on several national and international organizations' board and program on research and policy for cervical cancer control. He has led several research work and on prevention, diagnosis, and capacity building on cervical cancer in Nigeria. He has more than 220 publications that is largely on HIV, human papilloma virus, and cervical cancer. Professor Isaac is also a sexual health advocate, particularly promoting safe sexual and reproductive and young adults. He is also a community man offering professional service to underprivileged girls and women through his Isaac Folorunso Adewale Foundation. Welcome with me, Professor Isaac Folorunso Adewale, for the chairman's speech. You're welcome, sir.
Thank you so much, Samuel, for that intro. I want to start by commending the organizers of this event.
Thank you, sir.
For putting Nigeria on the global map. We are dealing with a disease that is as old as humanity, but yet represents essentially a disease of inequity. Cervical cancer intersects with issues of social justice, including empowerment, poverty, and education. And certainly for many of us interested in social and reproductive justice, handling cervical cancer is to me is a priority. It's a public health issue, and one of the things that has gladdened my heart is the launch of the global initiative yesterday of the 90-70-90 agenda. That agenda seeks to ensure that 90% of our girls are covered with HPV vaccination by 2030, and that we offer screening to 70% of our women, and that we offer treatment to 90% of women with precancerous lesion. It is envisaged that we can drastically reduce the incidence of cervical cancer in our population if we diligently keep this agenda. Well, let me say clearly that no country can do it alone. There is need for collaboration. There is need for political commitment, political action at the topmost level in every country. I know Nigerians, when we are determined to do something, we'll get it done. And I'm optimistic that if we agree to work together, certainly we can make cervical cancer a thing of history. I told someone a couple of days ago that the picture has largely remained unchanged. That woman with foul-smelling discharge, that woman with advanced cervical cancer. You can change the narrative, and the time to do so is now. Thank you so much for putting this together. I believe that we can rewrite history. We can put a smile on the faces of our women, and we can bring Nigerian back to the path of sanity, where cervical cancer will become an object for the museum. Thank you so much. I wish all of us an interesting session, and I believe that we'll be able to document for posterity the proceedings of this event. We should move beyond just talking. I think the beauty of today's presentation should be that we will go back to our respective facilities, respective communities, and preach the gospel of screening, and tell everyone that cervical cancer can be eliminated. God bless Nigeria. Thank you.
Thank you, Prof. Sir, for the opening remark. We will bring an end to cervical cancer with collaboration and support. Thank you very much, sir. We appreciate your opening remarks, sir.
Yes, with the permission of the chairman, I will request that you give us the go-ahead to introduce the First Lady of Kebbi State, Dr. Zainab Shinkafa Bagudu, to give a goodwill message, because we heard that there's an important meeting that she needs to attend now. Dr. Zainab is the First Lady of Kebbi State.
Shinkafi.
She's an advocate. Thank you, sir. She's an advocate. She's the founder of Medicaid Cancer Foundation.
Medicaid.
Medicaid Cancer Foundation. Thank you, sir. And
Thank
she's
Moderate.
And a member of the board of UICC.
Thank you,
Wow.
sir. Good morning,
Thank you.
Prof.
Good morning, Your Excellency. Thank you for the good work that you are doing, not only for Nigeria, but for humanity.
Thank you for your support. That board seat came through you the first time. Your endorsement was invaluable. Thank you, sir.
And please convey our best regards to His Excellency
I will
for
do so.
supporting issues relating to cancer.
Yes, I will do. So I guess my introduction is over. I'm supposed to give a goodwill.
Yes,
Yes.
ma'am, please. Yes, ma'am,
Okay.
please.
Good morning, everyone. I'm sorry I just joined, so I'm not quite sure who is on. I see Prof. And if you
I think we have about 82 attendees as of now, and we're still counting.
Do we still have you, Your Excellency?
It might be an internet problem. Let's just give her a minute or two. I'm sure she will come back.
Yes, sir.
I think we can introduce the next speaker. When Her Excellency Zainab Bagudu Shinkafi comes back, then we will take her.
Thank you, Prof. You can go on, Dr. Wilker, please.
Yes, before we proceed for the lecture for today, we employ that you could use the chat rooms for comments, contributions, and questions. And should you have the need to speak, please contact the moderators who would oblige you if time permits. Our guest speaker for today will be addressing a very important topic, exploring Nigeria's pathway to achieving 90-70-90 targets. He is Professor Aruna Duru. He is a professor of obstetrics and gynecology, Department of Obstetrics and Gynecology, Just University Teaching Hospital, Just Plateau, Nigeria. He is a board member and a board member of the Faculty of Obstetrics and Gynecology, and also West Cervical College of Surgeons. Sir, we welcome you to the floor, sir. You have the audience, sir. Before we go on, sir, we would like to quickly recognize the First Lady of Ondo State, Mrs. Betty Anya Wakiredu. You're very welcome, ma'am.
Professor Daro, please, can you hear us, please?
Thank you for having me.
You're welcome, ma'am. Professor Darrow, please, you have the floor, sir.
Thank you very much for that introduction. My mic was initially muted by you, but I'm happy you have finally done it. Just for some corrections, I think the topic has been changed to cervical cancer screening, the Just University Teaching Hospital, but I'll try and see how we can incorporate the whole concept together. So it's my honor and privilege to be here in the midst of my mentor and my teachers, Professor Isaac Adewale, and all the other people that are on today. I'm supposed to give a 15-minute lecture, but I don't know how I can do much justice to this important topic in 15 minutes, but I'll try my best. If Her Excellency permits me to go ahead with the lectures.
Yes, sir. Please go ahead, sir.
Can I proceed? Just want to be sure.
Yes,
you can,
Prof, sir. You can proceed, sir.
Okay, so I'm going to share the screen right now so that we can all be part and parcel of the whole presentation. Like you are aware that cervical cancer is a very important topic for all of us, and we're going to look at that in some detail today. Before I start, I must say that I have a conflict of interest, and that conflict of interest is that I am an advocate of women's rights, and therefore I will be very happy to be part of this program to promote the prevention of cervical cancer. My work has been cut short by the fact that I've been asked to look at the cervical cancer prevention generally, and then to look at what we have been doing in Jos University Teaching Hospital for the past 13 years. And I'm happy that my friend, Sesan Olu, sent in this picture. I'm sure you can recognize this picture, which is coming from the University College in Ibadan. Can we see that? Just to be sure. We are communicating. Anybody in the affirmative so that I can move to be sure we are all seeing my screen?
Yeah, this from
yes, so we are seeing your screen, sir.
Okay, beautiful. This picture is was sent in from.
It's from Oshogbo.
But this is from Oshogbo, sir.
Yes.
Oh, this is Oshogbo.
Yes,
Okay.
sir, not for UCH, sir.
It's just to demonstrate that this. Yes, this is to commemorate the Cervical Cancer Prevention Week that we are all doing right now. Now, we all know that the best way to prevent cervical cancer is abstinence, which we all know is impossible when it comes to the human race, except a few people who have decided to join the other lineage to become either a priest or a nun or whatever they decide. But we also know that another way of prevention of cervical cancer is by immunization, which is the best way to prevent cervical cancer at the moment. Now, just like the chairman has said, there's a global strategy that by 2030, 90% of girls should have been immunized against the human papilloma virus. The reason is that so that by 2030, cervical cancer will be eliminated, just like we have currently eliminated polio in the country. And by that 2030, 70% of women should have been screened for cervical cancer by the age of 35 and by 45 years of age. And 90% of those that have been screened and have some cervical lesion, especially precancerous lesions, would have been treated effectively, including those with obvious and overt cancers. That is the target. And you and I know that there have been targets and targets and targets by WHO for a long time. But can we meet this target? But before we go there, let's look at our current scenario. What are we like? Again, this picture was sent in from Oshogbo, that we all know, and courtesy of Shekinat Bola Oye Bamiji, who agreed that I can use this picture. Now, primary prevention for us as a country at the moment is feasible, but are we doing it? The answer is that most of the time we do not do it. Why? Because immunizations are haphazard. The cost of immunization is so much that most parents and most girls cannot afford it. And therefore, out-of-pocket expenditure for immunization is seen to be not cost-effective. So what we currently what we are currently battling with is secondary prevention, and that is screening. And the best way to screen is using HPV. But as a country and as a nation, HPV screenings are in only few places. Most public institutions do not have facilities for HPV screening. And therefore, it's only the private facilities, a few of them, that are able to do HPV screening. So therefore, we are forced to concentrate only on VIA, on villi, and pap smear, and then colposcopy. And that's what most of the health facilities in this country currently do. We all know the drawbacks of each of them, the VIA, the villi, and the pap smear, as well as the colposcopy. In fact, despite all of this, not many tertiary institutions have facilities for colposcopy, unfortunately. And therefore, they are limited to VIA, villi, and pap smear because of that of equipment and also the personnel. Now, prior to 2007, in the Jos University Teaching Hospital, what we have been doing has been opportunistic screens. And what we mean by opportunistic screens are that only patients that request for it, or we suspect that, or they will think that they require pap smear, that we do that screen for them. And therefore, for the 25 years prior to 2007, we have screened less than 1,000 women. That means we are screening only about 40 women per year, and that was grossly inadequate. And so how did we now move on? So we now developed a strategic plan as a hospital and also as a department, that we are hoping that by 2020, 50% of our women would have been screened for cervical cancer. And that was our strategic plan. We only believe that hopefully that would be achievable. So we now moved on to look at the cervical screen. And we started in earnest in 2007. So we started organized screens in 2007, courtesy of Professor Adewale, who was the principal investigator of Operation Stop Cervical Cancer in Nigeria, who graciously chose Jos University Hospital as one of the hospitals he was going to work with among the other 6 teaching hospitals in the country. The others were in Port Harcourt, the Enugu, Lagos. Of course, you know that Professor Adewale will not leave his home hospital, that is the UCH Ibadan, then ABU Zaria and Jos University Teaching Hospital. So that was when the program started. He organized the training of trainers. He organized the facilities that each of these institutions was going to have. And we were one of the beneficiaries. And therefore, in Jos University Teaching Hospital, which you are seeing on the screen, which is a 600-bedded hospital, currently is well equipped to handle a lot of screening facilities, screening for cervical cancer. And that is what we're doing in earnest at the moment. And courtesy of the team that we currently have. So we organized that department and the unit within the clinic complex to have a cervical screening unit as part of the gynae oncology division of the teaching hospital. And that unit is well staffed by lots of dedicated people like Professor Jonah Musa, who many of you may know him, and Professor Silas, the pathologist, Dr. Shambe, Dr. Magaji Ajang, and recently Mariam Ali, who are also part of the team. In addition to the consultants, we also have dedicated nurses like Joyce Asufi and her team that are really working tirelessly to ensure that these women are properly screened. And how do they do that? And how do we do it? We have a robust unit whereby these patients are properly screened. And in the screening, you will find out that a lot of the patients, after being screened, they leave for home and wait for the result. But while they are waiting at home after the pap smear has been taken, these nurses especially use their resources to call the patients to come back for feedback. So they have been doing that for the past 13 years because of the dedication that they have. And once, for instance, it is the pap smear shows that there are some lesions, particularly high-grade squamous intraepithelial lesion or the low-grade squamous lesions, and they have done it about twice, they recall them back so that they will come for colposcopy. And that is what they have been doing for the past 13 years. Again, these are the equipment that were donated to us, courtesy of Operation Stop Cervical Cancer, and they are currently working. They are still working. Almost all of them are working, including the cryo machine, the lips, and everything is working. Recently, we've also acquired the digital colposcopes that are being deployed to use. Now, at the moment, we have screened over 23,000 women. We have done about 23,000 screens in the last 13 years, meaning that we screen an average of 1,800 per year compared to 40 per year we had previously been doing. And to me, that is significant. But is 23,000 sufficient? When we calculated it, we found out that it's only 0.1% of the women on the plateau that have been screened. So we have not even reached 1%. And despite the figures, the large figures we have, it appears large, but in reality, we have not screened sufficiently. And therefore, we have to begin to think of ways to improve our screen so that more and more women will be screened. The results of the screen shows that we have done cytology between 2007 and 2020. About 23,000 of them have been screened, like I said, and 80% of these are normal, which is expected. If you look at the literature, most of the screens will be normal, but only 7.1% were typical, and then 3% were high-grade squamous intraepithelial lesions, which we now proceeded to do colposcopy for. So we've done about 2,225 colposcopies, meaning that we've done about an average of 171 per year. I usually don't count 2020. Why? Because 2020 is the year of coronavirus, and most of these colposcopies have not been done. We've not done much this year because of the coronavirus. Why? Because of the effect of coronavirus vis-a-vis the colposcopies itself. Because during colposcopy, you don't only just do colposcopy in June, we do colposcopy and treat if the need arises. So we're afraid and we're worried about the effect on us, even the healthcare providers, despite the use of PPEs. So to me, effectively, this figure is what we have been doing in the last 22 years since we started this procedure. Now, histologically, like I said, we had about 1,225, and then 70% of them were normal. And then we had 24% had CIN, and then 6% were obvious cancers. So therefore, when we did a...
Professor Daru?
Yes, sir.
Your slide is not moving, so we can't see what you are presenting.
Oh,
so
there, I'm sorry.
Move your slide as well.
I've been moving, probably it's not showing there in the screen share.
Yeah, but you're in control. Yes, now it's moving. So you have to move. Oh,
it's moving now. Okay, can you see that now?
Currently, you are telling us, at least displaying the number of the histological pattern.
Beautiful,
and
sir.
Number of cancers you prevented.
That's fine. So is the screen moving now, sir?
Not again. Can you move it? Let's see.
I've done that.
Now it's moving.
Okay.
Currently, you have cytology.
So I see where the challenge is.
Okay.
Great, sir. So currently what we have is that the cytology shows that most of the patients we have done are totally normal, and therefore there was no need for worry, and therefore we rescheduled them for either 2 yearly or 3 yearly screens. But a few of them had high-grade squamous intraepithelial lesion, which you can see down there, and then some of them had low-grade squamous lesions or atypia. These are the candidates we usually would want to do colposcopy for. Again, this slide shows, I hope you are seeing this slide now. It shows the histological type of the cancer. Remember I told you that about 6% of them had obvious cancers, and most of them, like we all know, are squamous cell carcinomas, which is the typical pattern. And then, but we still have a few of them that are adenocarcinomas, like you can see here, and then we have some that CIN, 23.6% of them that were CIN. Please feel free to let me know if you can't see anything. Now, how do we manage these patients? Most of them, we do the colposcopy for them, and then we lead them to take it for histology just to confirm what we have been thinking all along. Then some of them undergo cryotherapy, and then a few of them we need to go through cold night, particularly where we think of cancers. Yes, sir.
Can we please interrupt you for a few minutes to allow Her Excellency Zainab Shinkafi Bagudu to say a few words? She has another engagement.
No problem. I'm okay, sir.
I'm sorry to interrupt you.
No problem, Prof.
Okay.
Okay. Sorry, technology, this is what happens. So good morning again. I think we have started the webinar, and I just want to put my own good wishes, congratulate the organizers and the participants. I see my sister has joined, Her Excellency Betty Akeredolu, the First Lady of Ondo State. Good morning, Your Excellency. We as a group in the different coalitions that I work with, and as a member of the UICC, as an individual and the founder of the Medicaid Foundation, we exist to support advocacy, to improve awareness, and to push for policy changes. And today, like I was saying, or this period that we're now seeing, is a very exciting one for us, because it is the time that finally we're seeing action being backed up by all the various plans that we have had over the years. So we're very excited that Nigeria is going to be starting the HPV vaccine. In my position in the state, all we have been doing is to help to create awareness, to improve acceptability of this vaccine. Some of you might be aware, we recently launched our cancer control plan just last week, and one of the few in the country now that follows on from the National Cancer Control Plan. It's very important that we make these plans, but at the same time, we need to back them up with action. The main issue that I find in my position as the CEO of a foundation is that of access to treatment, access to funding for diagnosis, for treatment, and to help us through the patient navigation. For this reason, we just look for viable partnerships both within and outside the country, so that our patients can have an easier life when they are afflicted with cervical cancer. Technology is not so high in our parts of the world, but the little that we have, or the ones that we have, are also very good in diagnosing and in screening our girls. But we're still going to need a lot of assistance if we're going to meet those targets of 90, 17, 90 on all the entire spectrum. So I hope that the partners on this call will look into that. I know that a lot has been done in the past, even under the former Minister of Health, Professor Adewale, and his predecessors. There have been training and capacity building from organizations like IAC, but we have not been able to fully utilize the technology and the capacity that some of these personnel came back with. For instance, I'm aware that we had a lot of oncologists trained and engineers, but they have not been able to have the facilities to work in, because we simply do not have those LINAC machines. So these are the type of improvements that we would like to see. And from our corporate organizations as well, I find it quite disheartening when I see Nigerian conglomerates contributing to a global fund like Gavi. It's very commendable, but at the same time, we do need our own type of fund. Is it time for us to come together and form our own collaborative funding, a Pan-African fund or Pan-Nigerian one to start with, so that we can improve the access for this vaccine? We're all aware that it's one thing to say that, oh, the vaccine is available and everybody is going to start it, but we are all aware that there is an intense and acute shortage of that vaccine, and there is going to be a real scramble for us to get our hands on it come 2021. I listened to the CEO of Gavi yesterday at the launch of the strategy, and he wasn't too encouraging. So we need to position ourselves in a way that will enable us to be able to access those vaccines, both from funding partners and from our own selves. I hope that the professionals here that come into contact with all the partners and bodies that are making the plans and the strategies globally will take this message across. Africa, even Nigeria, as big as we are, we're simply not able to fund these plans on our own. And all the assistance and support that we can get is still very welcome, despite our economic classification. So once more, I'd like to say a big congratulations, and I wish you all a very fruitful webinar, and I will look forward to the take-home lessons. Thank you very much.
Thank you, Your Excellency, for your goodwill message. We count on you. There is a post in there, because you plan to leave, by Aisha Mustafa about the availability of treatment centers across the country. I want to plead with Her Excellency to help us look into Udus. Sokoto has a LINAC and a brachytherapy, but they break down readily. But there is a need to support Sokoto to take care of many of the patients in the Northwest, including Zaria. Zaria too has a center. So please, Your Excellency, I want to commit you to help us to sort this out. You can help use your reach to reach out to the governors in Sokoto, in Kebbi, and also in Kaduna. Thank you.
Thank you, sir. I will continue to do that. We have been on it, as you are aware, and I will continue to do it. Unfortunately, our federalism is in a way that our federation, the laws, is set up in a way that what happens at the federal level is different from what happens at the state level. The teaching hospitals that have these machines are federal institutions, and the state governments are all in their own silos. And for us in Kebbi to fund an institution situated in Sokoto, it's an economic issue, it's a federalism issue, it's a political issue. So I have been on it, as you are aware, and I will continue to find ways in which we can weave around it to find a solution so that we can invest in it all together. That's what I mean when I say a pool, and start thinking as one, as opposed to all these obstacles that we face. But I will, thank you. Is that it? Are they not hearing?
Hello?
Yes.
Thank you, Your Excellency. I think we can now go back to Professor Daru to continue his presentation. Professor Daru.
Thank you very much, sir. And I appreciate, we want to thank Her Excellency for being on this and for all the goodwill messages she has tried to deliver. I think the organizers and myself were very grateful for your active participation in ensuring that our women are well taken care of. Just like what I said earlier, and my chairman and the others, we have a very active colposcopy unit, and this is what is currently on. I hope we can see the screen now, just to be sure. My chairman, sir, are you seeing the screen, sir?
Yes, we can see it.
Yes,
okay,
go
that's
on.
great. Yes, these are the equipment that were donated by the Operation Stop Cervical Cancer in 2007, and we've been using that up till today, but we've also acquired a few new equipment, including the digital colposcope that will soon be deployed. Like I'd say, just as a recap, that at the moment we are screening about 23,000 women. That's over the last 13 years, which is an average of 1,800 per year compared to 40 per year that we previously had. I think that is a significant improvement. However, just like I'd said, this figure looks large, but we've only screened less than 0.1% of the women that require screening on the plateau. And therefore, we've not even achieved the 50% we had set for ourselves in 2017 by our strategic plan, not to talk of the global reach. So if we are screened 23,000, it looks large, but to us, it's still grossly inadequate. And out of this, the cytology was about 23,000, and 80% of them are normal, and then only 7%, about 10% generally, required colposcopy. So we did about 2,225 colposcopies, which is about 171 colposcopies per year. I tried to exclude this year because, like I said, this year of COVID, and with COVID, you have to be careful when you are doing colposcopies because of so that the healthcare personnel themselves do not get exposed, because we don't generally have to screen the women for COVID before they come for colposcopy. Now, the histology, like I said, most of them are normal, but we have about 6% of them that were obvious cancers. And these were now moved into the treatment trials that were set up for ourselves. Unfortunately, JOS is one of the centers that does not have radiotherapy equipment. It doesn't have a radiotherapy center. And therefore, most of them may require to be moved to Zaria, which is the nearest. And just like the chairman had said earlier, even Zaria is working epileptically. And then most of their equipment are, one moment is working, the next moment is down. And therefore, sometimes we have to send them to as far away as Gombe or even Abuja. But like we all know, the patients that have cancer are among the poorest in the society. And when you tell them that they need to move beyond JOS, most of them will say, I'd rather stay at home and die. And therefore, we have to now move on to start chemo palliation for them. And that's what we currently do for most of these patients. This is a graph to show the pattern, the type of cytology we have. Like I said, a few of them are atypical. Most of them are low-grade squamous lesions. A few of them are high-grade squamous lesions. And these are the patients that benefit from colposcopy. Now, the histology among those that have cancers, majority are squamous cell cancers, like we all know, because we're dealing with cervical lesions, but a few of them are also adenocarcinosquamous lesions. And I'm saying that so that we are aware that there are other lesions, including things like adenosquamous cancers and then the adenocarcinomas. Now, how do we manage most of them at colposcopy? When we do the colposcopy, we're after looking at them where it's totally normal, we don't bother. We ask them to come back for a repeat pap smear or colposcopy. But where there are lesions, we leave them. And when we leave them, we send it for histology. We also have facilities for cryotherapy for a few of them that require it. And then those that have obvious cancers, we now do cold knife biopsy. We do an examination under anesthesia, and then we take the biopsies for histology and also for confirmation. Like I said, for those that have early cancers, especially stage 1, most of them, we offer them radiotherapy, but because many of them will refuse, we go ahead and start chemotherapy. But late cases usually is chemo palliation that we generally do in this facility. And the chemotherapeutic agents are mainly platinum-based and also the taxane group of drugs that we use for the patients. We all know how expensive these drugs are, but many of them will struggle because if they have cancers, many of them will struggle and look for funds to ensure that they get the treatment that they require, despite the explanation that radiotherapy is also an important component of the treatment. So how did we get to where we are as an institution? The first is that we have a lot of institutional support. The teaching hospital has been able to be very supportive. They have pegged the cost of screens to about 500 Naira per patient. And I think that's one of the lowest anywhere within the country. I suspect there are other centers that probably have a similar thing, but the hospital has been very supportive in that regard. Like I said, we have a very robust team of people within the place who are very active and ensuring that these patients are screened. What we have done as a setup in JUF is that the screening center, the cervical screening center is within the clinic complex. So the patient does not require to move elsewhere for anything. So all she does is that she comes to the clinic, either for antenatal clinic or gynae clinic or for family planning, and they will discuss pap smear with them, and many of them opt in and they go ahead to do the pap smear. Then we have a lot of collaboration also with other faith-based groups, the churches, the mosque. They call us, we go and give them health talks. Almost every person in the team has given one health talk or the other. And this has improved the awareness among the public. And therefore, after those health talks, you will see a surge in the number of people who come for pap smear. And from there, we can now harvest those that require colposcopy. And in addition, most of the team members are subspecialized into oncology, including the nurses who have gone for specialized training into oncology and nursing to ensure that they appropriately manage the patients as they come. Do we have challenges? That is obvious. There are lots of challenges. The biggest challenge is funding for consumables, for reagents, for the procedures, for the drugs. Those are major issues because many of these patients, do out-of-pocket expenditure for this procedure, and many of them cannot afford it. For instance, like I said, the hospitals has been gracious enough to peg it at 500 naira for pap smear screening, but colposcopy is expensive because there are many other things that are required, and therefore, the patients have to pay for it from their pockets. So that's a major issue. The consumables, they get exhausted periodically, and therefore we need support in this respect. And those that require medication, especially those with obvious cancers, they find it very expensive. And many of them, after 1 or 2 or 3 courses, you see them disappearing. When they disappear, it's either because they don't have the money after a phone call, or they don't come because they have died or because of some other concerns. They have opted for other alternative treatment for their obvious cancers. Now, the other major challenge we have is we don't have radiotherapy center in Jos. It's a major concern, like I said, because once you make a diagnosis, a woman has cancer and she requires radiotherapy, if you ask her to move beyond Jos, most of them will rather go home and die or seek alternative treatments from traditional medicine or other ways of trying to heal themselves. Then we have another concern, which I have tried to discuss with the pathologists, is that when you look at the patient clinically, what you see clinically is totally different from what you see based on their histology reports. So we have that challenge. I don't know whether other centers have that, but once in a while we have that. And when we have those kind of discrepancies between the lab results and the clinician, we sit down and discuss and see how best to iron it. And I can say that our pathology unit, the pathology department has been very supportive, led by Professor Silas, who have been very supportive, ensuring that these issues are resolved where it is available. So what's our next steps? Our next steps will be increased sensitization. We need to do that. And I'm happy that this lecture is ongoing so that we see the need to talk more to our clients, especially our patients. And not only the patients, in the general public. And I'm happy with what Her Excellency is doing in Kebbi State. They are sensitizing more and more people to be aware that they need to come for cervical cancer screening. It is very important. But you and I know that our population is such that many of them will say, let me not go for screening, and they'll go and discover a problem. And what I don't know will not kill me. But you and I know that it's not true, that we need to sensitize them more. Then we need more institutional support, especially for colposcopy, because colposcopy at the moment in Jos the cost is increasing. It's about 10,000 naira for colposcopy when you have to also do a lip because of the need to do the histology. So that is quite expensive for most patients. And therefore, if we can find ways to support these women, that will go a long way. And we also need an oncology center, especially in this area. There's none around except in Abuja. So an oncology center is long overdue in a place called Jos. And we need more gynae pathologists. NHIs may be able to resolve this issue if it is incorporated and agreed upon to be incorporated as part of the necessary things that the women need for their health. So if NHIs can take off that burden from the patients, I think it will go a long way in increasing the uptick of cervical cancer screening in this place. So what is the way forward? I think the way forward is to move into aggressive HPV screens, because that is less invasive. Hopefully it will cost less. You don't need a lot of laboratory personnel to handle HPV screening. And I'm happy with what Rekia is doing. She's using GeneXpert to do HPV screening, which is very good, where patients can even actually take the specimens by themselves. So if we can go that way, I think we will go a long way. We should be able to move to liquid-based cytology, especially in JOS. I know a lot of centers are currently using liquid-based cytology, but it's not universally available. Then I think almost every facility needs a tumor board. The tumor board will help you to chart the way forward to handling cervical cancers. And we need to reduce the cost, or somebody has to offset the cost of cervical cancer screening. And last but not the least is the need for immunization. It is the key. And that's why the 90-70-90 is important, that we hope that by the 2030, over 90% of our girls should be immunized for cervical against HPV. And once that is done, I think by the year 2030, we may almost completely eliminate cervical cancer. For us, it is one step for youth, but we think it's a giant step forward for a country like Nigeria. I want to thank you for the opportunity to do this presentation.
Thank you very much, Prof. Sir. That was a very enlightening lecture. Thank you, sir. I would like to move to the next agenda, and I would like to crave the indulgence of our chairman, Professor Adewale, to just quickly recognize some stakeholders in our midst. Everyone is important. I might not be able to recognize everyone, so please bear with us. We have the president of Nigerian Cancer Society, Dr. Adamu Halazan Huba. You're welcome, sir. We have the president of IOTIC African Organization for Research and Training on Cancer, Dr. Abubakar Bello. You're welcome, sir. We have in our midst also Dr. Mini Osaji, M1 president, national president. You're welcome.
Have you recognized Her Excellency, the First Lady of Ondo State, who is also the founder of Brecan?
Yes, we have, sir. You're welcome, we have, sir. We have in our midst also Mrs. Betty Hanya Wakiridulu, the founder of Brecan. You're welcome once again, ma'am.
Thank you.
Yes,
you've already recognized me.
Yes, ma'am.
Well, it's never too much, Your Excellency. Thank you. Thank you for your good work.
Right. Thank you.
Thank you so much, the chairman, sir. As we move ahead in this agenda for the meeting, we are privileged to have with us Dr. Andre Cavao to give us the next lecture. He is a scientist at the screening group of the International Agency for Research on Cancer. Dr. Cavao obtained his MD in Brazil and his PhD in oncology from the University of Sao Paulo, Brazil, and a MPH from University of Washington, USA. Dr. Cavao's main interest is to work on implementation science and building capacity as tools to improve cancer control and quality assurance, particularly in resource-limited settings, just like we have in Africa. I will welcome on board now Dr. Andre Cavao to give us his lecture. You're welcome.
Thank you so much for this invitation. and for being here to discuss with you how can we help somehow Nigeria to get to the 979. You know, I got contact a few weeks ago by Dr. Isaac, Professor Isaac, you know, on our project that we have is the Cancer Screen 5. And as we are talking how Nigeria could participate in that program, right, he asked me to make a presentation here, and I congratulate Nigeria for this effort to put together, you know, this discussion on how can we achieve the goals for cervical cancer elimination. So I'm gonna share my presentation, and I'm gonna talk with you about our initiative on cancer screening in 5 continents, and how I see that that initiative could help Nigeria to achieve its goals, right? So we have launched last year the Cancer Screen 5 platform, and this has the national that there is a lack of available and accurate data on screening policies and activities worldwide. So we don't know what is happening around the world regarding cancer screening in a single platform in an easy to see information. There is a difficult to access that information, so many different sources, and then so many questionable sources that we don't know exactly what's happening. And this is important for us to move forward, and the need for harmonization so we can compare the results across different nations. So the idea of the project is to collect and disseminate information on cancer screening practices and programs globally in a way that that information is harmonized by the data collection. So everybody's collecting the data in the same fashion, so that can be comparison. And with that, we could assist countries and organize that health information system and get a better cancer screening program. Right? So how that fits in the 979, right? We are not talking here about vaccination, but we are talking how to get the 70% for the screening. And to do that, you need to know where you are, you know where you want to be, and you probably need to have a roadmap to get there. And the Cancer Screen 5 is all about where you are, is understanding where you are. In that sense, we collect qualitative data from the countries, right? And qualitative data means how your screening activities is organized in your region or in your country, right? What are the source documents you have? Also, how you organize. Do you have a team that take care of cancer screening? Do you have a budget? Somebody comment on that. It's very important to have a budget to guarantee a cancer screening. What is the policy for it? Did you try to pilot it? Is it free of cost, right? This is the way to move forward. And we ask how far in that way you are, right? Also, you would answer, what is the information system you have? Do you collect data in the individual basis or only aggregate data? What is the purpose of the data? All the steps of the screening process are just part of it. Do you link your data for screening with other data, with your cancer with your cancer register that knows your incidence and mortality, with hospital records, so you know if that woman that you screened and was positive for cancer, does she get the treatment? What was her clinical stage? Most important, what is the quality? What is the protocol you have, right? Are you using an evidence-based protocol? What tests you're using to screen? What is your target population? What is your interval round? Is that being respected, right? We see more and more that if you have a very fragmented system, you are probably doing a lot of screening in the same woman instead of having more women screening. So sometimes women got screening every single year instead of in an interval as proposed, right? Do you have an invitation? Do you follow to the further assessment? And importantly, do you have a quality assurance in your program, right? Do you have a guideline? Everybody's following that guideline. Do you have a team for quality assurance? What is your indicators and what is your report? Of course, this seems too far away. This seems too kind of complex. But as Professor Isaac was looking at the forms that we have, right, he began to realize this is also something that can help you through the process, as looking as the things that you should be done or should have help you to build upon what you need to do, right? And all those forms are freely available in our website for the Can Screen 5. Also, we try to collect the minimum of quantitative indicators, right? If you think about the process of screening, you have your target population. If you have an invitation, you invite all the women that should be screened on that year. Some of them will come and participate on our screen. Some of them are going to be positive and going to need further assessment, right? And then you should know how many actually got to further assessment, right? From those that need colposcopy, how many actually got colposcopy? From that got colposcopy, how many did a biopsy and you have a confirmation of cancer? Of those, how many got to treatment? And that's how we got to the 9th again, right? If you do this in a fragmented way, we know how we can get the 70% of a screened woman, but we don't guarantee the 9%. We cannot have women lost in the system with a positive diagnosis without access to treatment, right? And then we should follow that. That's how we know that our screening program is working, that we do all the steps. And was Professor Patrick that just gave a lecture before me point out this very nicely, right? That he has all the steps in his process, all the women that he screened. He knows the ones that need colposcopy. He knows the one with cancer, and he knows the ones that treat them. Of course, and he point out that his clinic alone will not solve the problem. He can see only 0.1% of all the women that needs. So a coordinated effort, a national effort is most welcome in that sense. So that's how we go for the quantitative form, right? We ask you what your population that should be screened and how many you are actually screening. Of those, how many got a positive test? How many got a negative test, right? Or you don't know the answer, or you don't know the result. Of those that were positive for a screening test, how many did colposcopy, right? And how many did not? On those that did colposcopy and got a biopsy or not, how many were benign lesions, or how many were positive for CIN 2, 3, or cancer, invasive cancer? And then some countries can get even to know the cancer staging and the treatment, right? But to follow the woman throughout the process is really an important step to get the 70 and the 9% on that. We also have the same thing if a country is doing VIA screen and treat or HPV screen and treat process, right? So kind of this was Professor Isaac asked me to be kind of short in time so we can eventually answer some questions. But the idea is that, when he saw in the website what we are doing, he asked me to bring here and try to showcase that this can be something that can be helpful when you put an event like that to discuss how Nigeria can achieve, the new goals regarding screening and treatment. And one way is to measure where you are, to understand, what we are doing and the numbers that we are doing, so you can plan how to get the 70% and then how to get to the 90% of women getting treated. With that, I will finish my presentation, and I'm open to answer to any questions. Thank you so much for your attention.
Thank you for Dr. Andre for that helpful information, and I'm sure that they are very useful to the audience. Before we proceed, I would like to seek the permission of the chairman with the way the lecture is going, that we should take the lectures together, then we take questions. Then afterward, we move to the goodwill messages. If that, the chairman, sir, do we have a permission, sir?
Please go on.
Yes, sir. Thank you so much, sir. I want over to my colleague now, Dr. Poluke.
Thank you, Dr. Samuel Kodayo. Our next speaker for today will introduce us to the Women's Right to Health Information Initiative, a WOT program on cervical cancer, a WOT program on cervical cancer. Dr. Mini Osaji is currently the National President of Medical Women's Association of Nigeria, M1. She's the Permanent Secretary of the Delta State Ministry of Health, as well as the Executive Director of Public Health Impact Research Center, a research-based NGO she founded in 2002. She's a fellow of the National Postgraduate Medical College of Nigeria since 2001. She's a fellow of the Royal Society of Tropical Medicine and Hygiene, 2002, and she's a fellow of the West Africa College of Physicians. Our research interests include COVID-19, maternal and child health, HIV and AIDS, gender-based violence, health system management, and women and youth empowerment. Dr. Mini Osaji, you're welcome. The floor is yours, ma'am.
Thank you very much for this opportunity to share the experience of the Medical Women's Association of Nigeria on the women's right to health information. I hope somebody can assist me with the slides. Yes. So this is the outline of the presentation that I'm going to give today. I will have an introduction. We'll look at some of the advocacy issues, needs assessment on resources for cancer screening in M1 state branches, of which we have 33 active state branches, plan of action to achieve project objectives in solidarity with M1 First Ladies. Congratulations to our men. My charge, becoming an M1 pink donor, and conclusion. I will try to see if I can do this in 10 minutes. So by way of introduction, M1 has just launched a very ambitious project on women's rights to health information, on cervical screening for early detection of cancer, as part of activities to commemorate Cancer Awareness Month. And this was done with support from our First Lady, Dr. Mrs. Amina Bello, as well as Dr. Mrs. Zainab Badugu, First Ladies of Niger and Kebbi States, respectively. Our target is screening 6,000 women across the nation over the next 6 months and treatment of those that are diagnosed with cervical cancer. That will be our contribution to 1970-90. The World Initiative was introduced in 2005 by the 2005 to 2007 National President of M1, Dr. Elino Wadinobi, who is currently the president of the Medical Women's International Association. For the advocacy issues, we conduct advocacy for things that are beyond our circle of influence. We have our circles of concern as well as our circle of influence. The circle of concern is wide. We are worried and bothered about so many issues. But our circle of influence is narrow because our resources, both time, funding, personnel, are limited. So we do the little we can within our circle of influence, but the things that are in our circle of concern, we do advocacy. And what are we advocating for? That screening for cancer should not be opportunistic, but mandatory. And health system deterrence to uptake human papilloma virus vaccination and then cervical screening should be eliminated. Health personnel, particularly family planning service providers, should be trained, and cervical cancers and cancer screening centers should be equipped and made accessible as well as affordable to women who need the service. We have local government reproductive supervisors, reproductive health supervisors who implement family planning programs, and they can be trained on cervical screening, as many of them already are familiar with the procedure of speculum insertion for intrauterine contraceptive device. Now, family planning and cancer control can now be integrated, and this will maximize human, material, and financial resources. We also want vaccination against HPV to be incorporated in the National Program of Immunization Schedule. States should be supported to establish cancer registries, and the 5-year survival rates for cancer patients should be used as an indicator for tracking progress in cancer control. There should be continuous and sustained advocacy to all states to have functional health insurance scheme. No state should be left behind. There should be, the state health insurance schemes should incorporate at least partial coverage for cancer treatment, and the same goes for the National Health Insurance Scheme. There should be legislation and initiatives that will make health insurance mandatory. Individual corporate responsibility, where the rich pay health insurance premiums for the poor, should be promoted, and efforts to raise funds for treatment of cancer patients should be supported. Now, where are we concerning the needs assessments? We did a need assessment amongst our state branches, and for those that responded, we found out that 9 states, M1 state branches, there is a presence of cancer screening that they control. If you look at them through the geopolitical areas, zones, North Central nil, Northeast nil, Northwest only Zamfara states, Southeast Ebonyi and Enugu, South-South Cross River, Delta and Rivers, Southwest Lagos, Ogun and Oyo. Then for the states with cryotherapy, we have 5 states. Sorry, the second slide is states with cryotherapy and thermoablation machines. We have the North Central only Benue states, the Northeast nil, Northwest Kaduna and Zamfara states, Southeast Ebonyi, South-South Cross River states, Southwest nil. So just 5 states have some form of cryotherapy or thermoablation that can be used to treat cervical cancer quickly after the screening. Then finally, for states with functional health insurance schemes, we got only 16. North Central, FCT and Plateau, Northeast nil, Northwest, Kaduna, Kano, Kebbi and Zamfara, Southeast, Anambra, Ebonyi, Imo, South-South, Bayelsa, Delta, and Southwest, Lagos, Ondo, Osun, and Oyo. So this needs assessment has shown us what areas we are going to consider carrying out advocacy to fill the gaps. Now, the plan of action to achieve the objectives of our project. How does M1 propose to achieve its targets of screening 6,000 women for cervical cancer? Now, first, we support awareness creation on cervical screening. M1 state branches are expected to implement the cervical screening project in one health facility in the state. They will present a letter from the National Secretariat to the Health Facility Management for permission to implement the project. And flyer on cervical screening is to be distributed during health talks that will be given by M1 members in the immunization clinic of the facility. Now, already 17 states have received funds from the National Secretariat to print 500 copies of the flyer on cervical screening for distribution to mothers that visit the health facility. They include Rivers, Kwara, Ogun, Kogi, Zamfara, Kaduna, Ebonyi, Delta, Benue, Enugu, Cross River, Oyo, Akwa Ibom, Kebbi, Sokoto, Bayelsa, and Katsina states. Then for the effective monitoring and evaluation of this component of the project, M1 state presidents have been requested to send their reports on health talks with the flyers to the coordinator of the WADI project, Dr. Uche Okwe. And this is the format, this is the data that we require. The name of the M1 member that gave the health talk, the phone number of the M1 member that gave the health talk for follow-up, health facility, the date of the health talk, the number of persons reached, female and male, and then the number of cervical screening flyers distributed, number of patients who have undergone cervical screening in the health facility monthly, number of cases of cervical cancer diagnosed in the gynecological clinic monthly, and the number of the cases of cervical cancer treated in the gynecological clinic and during outreaches monthly, as well as the number of calls received by the phone number on the flyer. Furthermore, in December 2020, M1 will commence the distribution of cervical screening flyers to 10,000 primary health centers across the nation. This will be done in collaboration with the national and state primary healthcare development agencies. Now, for the support for cervical screening, for us to reach our target of 6,000 women in 6 months, each of our 33 active state and FCT branches will have to screen about 180 women at the rate of 30 women per month. It doesn't have to be done monthly. They can actually do them at once. Now, this should include those that come to the health facility on routine basis, and that's where creating awareness in the immunization clinic will help increase the number of people that come to the health facility to access cervical screening, as well as specific outreach programs that M1 has actually been carrying over the years. We have been doing a lot of outreach for cervical screening. Now, given that the cost of pap smear is on the high side for an outreach, we have recommended that state branches do the visual inspection with Lugos iodine, as well as the visual inspection with acetic acid for the outreach. And then those that are positive can be referred for pap smear. When the state branches wish to conduct an outreach, they are supposed to contact the WADI project coordinator and inform her of the dates of the outreach so that she can work out the logistics for obtaining support from the National Secretariat. Already, 2 states have done cervical screening in the past couple of days, Edo State as well as Enugu State. So we are working to see how we can contribute to that activity that they have already implemented, particularly the treatment of those that have been diagnosed. So the National Secretariat plans to support screening of 200 clients in a maximum of 2 phases. Then for the treatments, how does M1 support treatment? The case for which support is to be provided must be referred by the state presidents of M1, who will provide relevant details of the case, which must be cancer of the cervix or cancer of the breast. Funds from M1 National Secretariat will contribute to investigations, chemotherapy, or surgery. Unfortunately, funds will not be used to cover the cost of radiotherapy. So already M1 has provided, since we launched in October, the cancer fund, M1 has provided support for 2 cases of breast cancer and a case of cervical cancer. Our first case is that of breast cancer from Delta State. She has had immunohistochemistry test done, awaiting the results, and 1 course of chemotherapy. She's due for the 2nd course on Monday next week. Our 2nd case is that of breast cancer from Osun State. She is currently receiving chemotherapy. Our 3rd case is the case of cervical cancer from Akwa Ibom State. On Thursday, tomorrow, she will have some investigations done, and the results will be available on Tuesday next week. And she can then be booked for examination under anesthesia for a possible surgical procedure. M1 stands in solidarity with our first ladies from Niger and Kebbi states who are carrying out fantastic programs in the control of cervical cancer through their organizations, and they still find time to support M1. In the words of the Honorable Minister of Health, Dr. Sage Hanire, Dr. Zainab Shinkafi Bagudu, a #cancer advocate and lover of the less privileged, has consistently championed patient-oriented programs, including free cancer screening activities through the Medicaid Cancer Foundation. Just yesterday, she led the Medicaid Cancer Foundation team to set off 90 teal balloons and also coordinated the lighting of the Emir of Gwandu's Palace in teal in solidarity with World Health Organization and the rest of the world to eliminate cervical cancer. Dr. Amina Bello Race Foundation provided free breast and cervical cancer screening from the 2nd to the 31st of October in Mina, and has gone further to offer free cancer screening as part of World Health Organization's global strategy to accelerate the elimination of cervical cancer from 10th to 17th November 2020. May God bless them. So these are some of their activities. the 90 teal balloons, the lightning, and the free cancers. Congratulations to our men. May I use this opportunity to congratulate His Excellency Senator Abubakar Atiku Bagudu, Governor of Kebbi State, for the commissioning of the Oncology Wards, Laboratory and Diagnostic Center in Calgo Medical Center, the launch of the Kebbi State Indigent Cancer Fund, as well as the launch of the Kebbi State Strategic Plan for Cancer Control. Indeed, around a successful man is a successful woman. I also wish to congratulate the Honorable Minister of Health, Dr. Osagie Ehanire, husband, brother, and father of great medical women, for taking action on two major health issues close to the heart of M1, namely maternal and child health, as well as cancer control, in spite of the challenge from the COVID-19 pandemic this year. My charge to all the distinguished ladies and gentlemen who have granted me audience in the last couple of minutes is, let us not glorify the problem of cervical cancer, but let us find at least one thing to contribute to eliminating. Let us find at least do one thing to contribute to eliminating cervical cancer. As many professional health events have been converted from physical to virtual meetings, saving huge finances usually incurred from air/land transport and accommodation, members of various professional health groups can channel these funds into proactive intentions, proactive interventions, even if it is in some pilot location, to produce tangible and measurable improvements in control of cervical cancer. One way you can contribute is by becoming an M1 pink donor today by generously donating to the project. All donated funds can be paid into our accounts, and you notify Dr. Agbonle or Dr. Onyi Onwa Wambuzo about your donation, and God will bless you as you contribute to this project. So we have our M1 pink donor book, which includes all our donors so far. We have received donations from 27 persons, totaling 1,003,000 naira. In conclusion, if we all chip in our little bits, I am sure we can make a difference in control of cervical cancer in Nigeria. Thank you and God bless.
Thank you so much, Ma. We can't overemphasize the importance of a Medical Women Association M1 in Nigeria. We appreciate your contribution and your passion for eliminating cervical cancer in Nigeria. Well done, Ma. Thank you for the lecture. We move on to our next speaker for today. We'll be speaking on harnessing the opportunities. We'll be speaking on harnessing the opportunities of the launching of global strategy for the elimination of cervical cancer in Nigeria. Is Dr. Ishet Lawal. He's the project director of End Cervical Cancer Nigeria. He's a gynecologist with the Federal Medical Center, Kebbi. He's a passionate cancer advocate whose mission is to promote collaborative efforts of cancer advocates in Nigeria. His research interest is in a search for evidence to guide resource appropriate management of cervical cancer in low resource settings. Dr. Ishet Lawal, you're welcome, sir. The floor is yours.
Hello?
Hello, sir. Yes, you're welcome, sir.
I can't share my screen. Can you see my screen?
Sir. Yes, we've enabled you, sir. You can go on, sir. You've been enabled, sir, to share your screen, sir.
I guess I'm having a, okay, sorry.
Okay, well,
but I'm having a problem with the, just like I share my screen. Well, again, while we're resolving that problem, because I'm having to share my screen. Oh. Not resolved. Okay, yes.
You're on, sir.
Yes, sorry, please. I'm trying to. Oh. I still can't.
Your screen is on, sir.
Okay, yes. Well, again, I don't even have much on my screen. Good morning, I guess.
Dr. Lawal, you first of all need to open the presentation on your desktop.
But can you see my screen now?
Yes, you can just see the Zoom 5.0 is here.
Oh, serious. Well, sorry, I think technology problem. So I don't even need my screen to really have this presentation. Just to say that thank you very much. I'm Ishaq Lawal, and it's been wonderful this past 2-3 weeks. It all started with a mail from my mentor teacher, Professor Adewale, asking us that we should see what we can do regarding the celebration of cervical celebration of launching of global strategy for elimination of cervical cancer. Before then, what the M1 president did not mention in the World Cervical Cancer Project was the fact that I had volunteered to be a freelance consultant to the project because I saw the opportunity in the project saying that they targeted 6,000 women to screen for M1 that has representation in at least 33 states of this country. I think that's a little bit low, setting the target too low. So I had volunteered as a consultant to that, and we are hoping that we can take that target to maybe 250, 300,000. At least each state should be targeting 6,000, 10,000 to screen. And I believe M1 can do that. So this collaboration, looking at the last 2 weeks event, my discussion was supposed to be talking about what next after this celebration. How do we annex the opportunities of the global strategy for elimination of cervical cancer, the launching of it? How do we annex that opportunity to impact on the burden of cervical cancer? And looking at this 2 weeks event, I really feel that, how do I put it? I want to go back into the history of how it all started. And when Professor Adewale gave us that assignment that we should look into that, we made a call to all cancer advocates. And the first person that responded, and that was the person that actually even gave us that energy, that boost. I feel that she should have some say in telling us, giving us the background of how this collaboration have developed in the last 2-3 weeks. And then I will talk about what we have put in plans moving forward. So Auntie, I call her my big sister, my Auntie Moji Animation. I will please, I'm putting you on the spot, man, because I'm just thinking about it, that this collaboration, this effort couldn't have moved this far without that your first response to our call that, look, let us come together and collaborate and see what we're going to do and how we're going to celebrate this, how we're going to celebrate the launching of global strategy for elimination of cervical cancer in Nigeria. So please, Auntie Moji, please, the moderator's chairman, I will please, if Auntie Moji is still on, I will seek indulgence that she should please talk a little bit on how she has guided us with her elderly wisdom into this discussion. And then I will probably in the next 2-3 minutes after she has spoken, hopefully I will resolve the issue with my slide and talk about our plans moving forward. Thank you. Auntie Moji.
Good morning, everybody. Thank you, Dr. Can you hear me?
Yes, Pa, we can hear you, Ma.
Okay. Thank you, Dr. Ishak. I'm very happy that I have this opportunity because this is something that's very, very, very timely, and then something that is being brought to the fore by someone I respect a lot. Dr. Ishak has always been an enthusiastic advocate for cancer care in general in Nigeria, and cervical cancer in particular. So I didn't even think twice about it when he said he was going to wanted to put together this collaboration for two reasons. Because I know that that energy that he has will permeate, and it's very important when you have somebody who is the glue for a particular project. If they're enthusiastic, then things will move forward. And also because it was an opportunity, this collaboration was an opportunity for us to see to come together as NGO, as corporate bodies, as government agencies, and have one voice for cervical cancer, and ensure that this one voice gives us a good, we speak the same language. I'm glad that the First Lady of Kebbi State, she was talking about how we all need to come together. We should have, even to the terms of having the buzzwords in our awareness campaigns, in our screening, the things that we say to people, the roadmap that we have in getting everything put together. We should be speaking with one voice, and this collaboration has shown us that we can do it. We started off with maybe 2 or 3 people when Dr. Ishak first mentioned it. Within 2 weeks, 3 weeks, we have over 30 NGOs and government agencies. We pulled together and we did the lighting for over 10 monuments all over Nigeria. We had very little funding, but we had a lot of enthusiasm. We rubbed each other off a little bit, but we stayed focused on what we wanted to do, and that was our main goal. And this has come by. We've had the lighting, and we've had this today. So it just shows that we are able to do it when we speak with one voice, and it's crucial for us to be able to attain the 90-70-90. We need to speak with one voice. We need to have a roadmap that is used from Sokoto to Lagos State, that is used from Enugu to Abia State. We all need to speak with one voice. We all need to put our data into one pool. And this synergy that is amazing that has gone on, I hope that we continue like that and we are able to achieve it. And I doff my hat at Dr. Ishak. You've done a really great job, and everybody, we really pulled this through. And I'm so proud. I'm so proud to be part of this movement. Thank you for the opportunity. Thank you. That's all I have to say.
Thank you, Ma, for laying that background, Ma. I really appreciate. And of course, we all could see what collaboration could do. Before of course, we've been able to come out together now. We are talking about launching End Cervical Cancer Nigeria project. We'll be reaching out to you very soon, and together there's nothing stopping us. And you could see that on the screen here is a list of the monuments that were listed still in Nigeria on the 17th. Before the collaboration, it was just 2 monuments that were on the list. But coming together, we were able to achieve much more than what individual could have achieved. And it's actually so heartwarming to note that on the WHO website, this Zoom is the only companion program that is happening on the WHO website for Nigeria. So, and I think there are less than 5 countries that are hosting companion program for launching of the global strategy for elimination of cervical cancer. So moving forward, we have a number of concepts that we're thinking through, but we can't, there's nothing concrete per se now, other than all of us, we need to create a platform for us to come together with our thinking cap, put everything on the table and come up with a one voice. Because, and agree that the target, the goal is that come 2030, when the stock is being taken for nations that are on the path of eliminating cervical cancer, Nigeria will be on that map. So that is the goal, and together we can achieve that. We'll be reaching out to you. Thank you very much for this opportunity. Hello.
Yes. Thank you, Dr. Ishak. We appreciate you for the presentation and for the input from Mrs. Mujani Mashan also. I will request the chairman to give us permission to take questions at this point in time before we move to the good message.
Please go on.
Thank you, sir. And I also hope that the lecturers are also at a last, so we can just take the questions, then we move. Okay, I will take the first question here to Professor Daru. What is the average age of the clients which HSIL in your center, with only 0.1% population screened in 13 years so far? How do you hope to expand the coverage by your team in youth? Professor Daru, sir?
Yes, thank you very much for that very important question that you have posed. Like I said, despite the large figures we apparently have screened of about 23,000, that constitutes about 0.01%, and that's not even up to 1% of the total population. We had looked at those figures, we had discussed them extensively, and we think that the best way is to decentralize the screening, because the majority of the women do not live within the environment of the hospital, which is about 20 kilometers away from the center of the city. And therefore, there's a need for us to move to the other satellite centers and begin to screen, and also in the other local governments. But that also comes at a cost. And therefore, we're looking for how to develop funding and seek for assistance to see how we can cascade this down so that more and more women will be able to access the screening services that are available within the center. In addition, we are exploring the use of VIA and VLI for women out in the outskirts, so that it's only women that we think that require to come to the hospital that may need to come over so that they can access the screening services that are available. Currently, we're also looking at the possibility of using the smartphone to be able to take those the pictures of the services at the periphery, and then we can now look at them, and where we think that they need to come over, we can call them to the various screening centers and be able to do that effectively. That way, hopefully we'll be able to screen more women. But equally important, like many people have said, is that we need to sensitize our public more. The public needs to know that every woman who is sexually active requires screening. And then we can now begin to look at the issue of vaccination for our young girls. And I think once we look at those approaches, most likely we're going to pick up significantly.
Thank you, sir. Professor Daru. This question is going to Dr. Andre Cabao. Please, this question goes to you. What specific activities does International Agency for Research on Cancer have to help LMICs establish national control program? Dr. Andre, are you there?
Hello.
Dr. Andre? Hello, Dr. Andre? Okay. Probably you will take that question when.
Logged out.
Hello. Hello. Can you hear me? Hello.
Hello, who's speaking, please?
Yeah, this is Ishak.
Okay, sir.
All questions to
We can't hear you, sir.
all questions to Dr. Andre should be typed out because he has left.
Okay. He's on the chat already. Those questions are on the chat.
Okay, thank you.
Yes. Okay, I don't really know who actually has this question, but let me just fill it out. Probably the chairman can help us redirect it. Is there any initiative encouraging mandating organizations such as NGOs who are screening on their own to share their data with the Ministry of Health?
I think is a moral obligation that if you are screening, you should send your data to Ministry of Health. But I thought I saw someone from Ministry of Health here, Dr. I saw his name, the former desk officer for cancer control. I hope he's still there.
Dr. Atuo.
Atuo, David Atuo, I saw his name. Dr. Ima Obong, I think Dr. Ima Obong is also from the ministry.
Sorry, sir, I'm not from the ministry. I'm from the University of Calabar and the teaching hospital.
Sorry
I'm not
about
a
that.
ministry official, sorry.
There's someone with who is also Ima Obong in the ministry.
Not Ekanem, definitely.
No, not Ekanem.
Okay, mine is Ekanem, not the one of the ministry. Good morning, sir. Good to see you.
Morning.
I think Dr. Atuo has been unmuted.
Okay.
I'm here, sir.
Over to you, David.
I'm here, sir. Can you hear me, sir?
Yes, we can hear you.
Good morning, sir.
Morning.
Pleasure to be here, sir, and to hear your voice once again.
Thank you.
Yes, sir. I've been listening in, sir. I'll take everything on board. Like you know, sir, there's I've been following up on the NCC program as it is now. I thought Dr. People who is now coordinating would have joined up, but he hasn't. So I'm just here to listen in and to contribute as much as I can. But for now, sir, I'll just do a lot more listening, and I'll.
Yeah, but is there a mandatory requirement that those who screen should send their data to the ministry? I'm not aware there's any, but I think it's a moral obligation.
Yes, there should be, but like you said, sir, to the best of my knowledge, I don't think there is, but I think there should be, and I think the ministry can maybe take, do a circular to that effect, or instruct at least our hospitals to bring that about, sir. Hello, sir.
Yes, please go on. Can we have another question?
Yes, sir. This question says that, please, can you speak to the primacy of community medicine and nursing in achieving the 90-70-90 goal?
Can I respond to that question? Dr. Sergi, can I respond?
You can go on, please, ma'am.
Please do.
Yes.
M1 President.
Thank you, former Honorable Minister. Thank you, Your Excellencies. Wonderful to be here. There is a very, very big role for community medicine, community nursing in this area. If you look back at my presentation, M1 is planning to distribute flyers to 10,000 primary health centers. That's one way in which we expect to reach out to the communities, because the primary health centers are actually the ones closer to the communities. Now, the community nursing is very, very important because many of the nurses that we have in primary health centers have not had the benefit of community nursing training. We have a few that may have gone for public health nursing, and these can be used interchangeably. With that training, or those who are already community nurses, when they get into the community, they are able to implement programs, they're able to implement the two-way referral system, they're able to follow up. So what you have is a situation where, first of all, they understand the public health programs that are prevalent, the public health conditions that are prevalent in that environment. So they know if a case of breast cancer, a case of cervical cancer comes, they know where to refer, and not after referring, they are going to follow up. It is a trained community nurse that knows how to do the home visit. Most of those who are not trained, when you ask them, go and do home visit, they say no, they want to stay in the facility. We also have the community health officers, the community health extension workers, junior and the senior ones. These are supposed to spend 60 to 80% of the time in the community. But what do we have? We have them staying in the facilities. I used to tell my community health officers, nurse, extension workers, and I tell them that, look, you cannot remain in the facility. You are not a nurse midwife. Your role is in the community, and the community consists of the schools, the churches and the mosques, faith-based organizations, the markets, community groups. So you must have a roster when you actually go out and interact. You meet with the World Development Committee and you tell them these are their problems and these are the solutions. The ones they can handle, they will support. The ones they cannot, they will do advocacy through the traditional leaders. So all that is missing for many of our primary health systems because we don't have community nurses and midwives in this environment. Then for the community physicians like myself, some of us work in the teaching hospitals, some work in federal medical centers. You must adopt a community where you actually practice the community medicine. You cannot just be doing teaching and taking care of residents. There must be a community that you adopt so that after the teaching, you actually have a place. I know that it is mandatory, but many times these things are done for accreditation purposes. We want a situation where at any time, that health facility, that community health facility you have adopted, if you go there, you see people from the teaching hospital joining with the community to ensure that services are there. So thank you for that question, and I'm happy for the opportunity to throw light on that issue.
You're welcome, ma. Please, before you go, I think let me also add this to the question that they need to ask you. I'm not sure that I heard you clearly, but someone said that why don't M1 collaborate with NGOs in different states so that more outreaches and advocacy program can be carried out?
Okay. Well, we're already doing that. We've been collaborating with so many organizations, and when we collaborate with them, we acknowledge them. And we have also told our state branches to collaborate, and the collaboration can come in so many ways. It can come in training, it can come in service delivery, it can come in awareness creation. So if we want to, in one state now, let's say we want to distribute 500 flyers, and you now say, oh, 500 is not enough. Come and let me bring 1,000. That's collaboration. So we pool our funds together, and on that flyer, we'll put M1, we'll put your organization. So since forever, M1 has been collaborating. During this biennium 2019, we have so many partners we've been collaborating. So if there's any organization that does not know how to reach us, I will just put my contact details tell us, we'll give you our directory. You get all the state branches, the presidents and the secretaries, and then you can just go to your state and start the collaboration. Thank you so much.
Can I say something?
Your Excellency, please fire.
Yes, thank you. Thank you. I just want to make a contribution as regards to why the Ministry of Health MIA is missing in action with respect to serving as a data bank or reservoir for data collection on screening, on cancer screening. The reason is this: they are yet to make a policy statement or have a policy position as regards to cancer. So if they don't have cancer as their priority on their priority list, there's no way the teaching hospitals will just carry data and dump in their offices. We must see them as serious partners in the fight against cancer, all cancers. Once we're able to do that, that synergy will be built, and we close this gap between them and the teaching hospitals where all these data are collected. And I think we have an amazing opportunity here with the launch of the strategy against cervical cancer. I know that the ripple effect will touch all other cancers, because if we are planning for the ministry or looking upon ministry to serve as a reservoir, it has to be for all cancers, not just cervical cancer. In addition, even though I'm here to give my goodwill message, but let me talk on the issue of screening in the hospitals or health centers. Once you make it a policy that in this hospital, any woman that comes around can have her breast checked and have cervical cancer screening, it goes effortlessly. It's no longer opportunistic. A doctor can't just start examining women anyhow without that hospital or that health institution having a position as regards to screening of women. And I thought I should bring it up. I've been discussing this with the Ministry of Health in Ondo State. And here we are lucky that we have many health centers. Nearly all local governments here have health centers. In some local governments, they even have two. It's just a matter of Ministry of Health issuing a circular and said, any woman that comes around, let her have this screening. And again, the nurses that are there, many of them, they have to be trained so that we use existing structures so that you don't have to start spending money recruiting those that are trained or have the knowledge. Those you have at the health centers, organize workshops, let them know how to do clinical breast exam. We can never, I don't know, let me not say we can never have doctors that will go around, but I know it will take years. But the nurses that are there, they can be trained to do clinical breast exam. They can be trained to do the cervical cancer training so that in no distant future, we can have this 90% we're looking at. We can have the 70% we're looking at. I'm not sure about the 90% of treatment, but I know 90% HPV vaccination, which could be done through a lot of advocacy, town hall meetings. And by the way, we may have the vaccine, the uptake might not be encouraging. We need to talk to parents. We need to have town halls. Having vaccines is one thing, the uptake is another one. So these are the things I thought I should just bring in very quickly Thank you.
Thank you, Your Excellency. I think there is also a posting from Dr. Amatu, who used to be the desk officer for cancer control at the Federal Ministry of Health, that when you do screening, you are actually expected to forward your data to the cancer registry nearest to you. And I think, Dr. Lawal, one of the things we can do is to also have a directory of all cancer registries in the country, because cancer registries are meant to collect data. And these data actually should be aggregated so that we can have an idea as to what are we really picking where in Nigeria. Thank you.
Thank you, sir. Thank you, ma'am. With your permission, Prof. Sir, can we move on to goodwill messages? We are sorry we might not be able to take more questions. We would reply via mail.
Go on,
we can
please.
see some.
Let's take goodwill messages. Those who have questions, you post them and indicate your email addresses so that we can respond. Dr. Lawal will coordinate the responses.
Thank you, sir. We'll start taking goodwill messages. We actually are going to call on you, Ma, the First Lady of Ondo State, to start the goodwill message. So you're welcome, ma'am. Please, we'd like you to go ahead with your goodwill message for today.
Oh, okay. Thank you so very much for having me on. Good morning, Professor Adewale, our chairman, for this Zoom meeting.
Thank you.
And co-advocates against cancer, quite a number of you are here. The Zoom has made it so possible for all of us to connect. Thank you all for all you do. I'm excited that this collaboration is moving like tsunami. And yes, it is. Nobody will give excuse, I don't have money to go to Abuja for meeting. This is what technology has done for us. It's wonderful. Let us maximize it. I want to give a shout out to Dr. Isaac Lawal. I think you're responsible for my participation. You chased me, even though Flag First Ladies Against Cancer, we are doing our own bits. A shout out to Dr. Z. Hello, well done. So Lawal pursued me, and I hope you are not disappointed with the input from Akurekan. We were able to decorate the gate leading to our home where my husband and I live is a serious traffic. So whether you like it or you don't like it, you must know that cervical cancer is being launched in Ondo State. And of course, all the BRCAN chapters in the Federation, they all decorated their offices. But most importantly, is the collaboration with FOWOSO, Foundation for Wives of Ondo State Officials and Female Appointees, is one group that I've been working with to raise awareness on almost everything. Breast cancer, rape, use it to empower women, use it to make women realize that they matter in this society. We are building up their confidence, they are bold, and they feel I can do it. I can do it spirit amongst Ondo State women. And I believe that such women, if we collaborate with them, that will really give a leap in whatever advocacy effort we want to embark upon, because they're increasingly becoming knowledgeable about their environment. And I can tell you that we are ready in Ondo State to take the fight against cervical cancer to the next level. Already, you know, I'm very much involved with breast cancer, and I see breast cancer and cervical cancer as twin devils. So for us to bring that into BRCAN, we are excited about it, because time and time again, women come to our office asking for help, asking for information about cervical cancer. And I can't tell you that we know it. We usually refer them elsewhere. But with this launch now, we're going to increase our scope of operation and bring cervical cancer on board. While the global strategies and goals are 90%, 70%, 90%, for us in BRCAN, we want to make BRCAN a one-stop shop for both cervical cancer and breast cancer, so that when a woman walks into our office, she gets all the information on the two cancers. And then when it also comes to screening, when we are screening for breast, we're also screening for cervical cancer. If we're raising funds for patients of breast cancer, we raise funds for patients of cervical cancer. We do a lot of data collection. We have some international collaborators working with us. We too will want them to look into cervical cancer. So by so doing, we're bringing everything we have into one basket or into one shop, so that one, it saves money. It also saves time or wahala looking for other specialties in cervical cancer when it comes to awareness and advocacy. I had already mentioned about the issue of the ministry. There's a lot of gap between what we are doing and the ministries. And I've harped upon it that our ministries are yet, especially at the state level, they are yet to see cancer as a health priority. But these days, we keep saying it that it's no longer the communicable disease. What is plaguing us in Nigeria now is even non-communicable disease. I see no reason why cancer should not be seen as a priority. And let them create a budget line. I don't know how many ministries that have budget line for cancer. And when organizations, NGOs, go to them to support them for events, no money. And you won't blame them because there's no budget or subhead for them to draw upon. You don't expect the commissioner or the permanent secretary to bring out money from his pocket. I'm not saying that on their own as concerned citizens, they will not do it, but they can fund. Maybe you want to organize World Cancer Day, you need them to be partners. Being partners, you expect them to fund it. Therefore, we need to nudge. I don't know who will be the person or the ministry or the arm of government that will make it mandatory that state government should create a budget line. Is so important. How did I get to know about this? When I went to US as a American Cancer Society university, that was one of the takeaway from that training. Make sure your government creates a budget for cancer. That's the only way they can support it. And you know, ministries, they don't have the time. Even the doctors in the hospitals, they don't have the time. It is the NGOs that run around nooks and crannies of this country, raising awareness, advocating. we need to support them. And the support should come from government. And of course, well-meaning Nigerians are corporate bodies. But I think the burden of responsibility when it comes to the fight against cancer rests on government. We need to make government realize this. We need to nudge governors forum to place budget for cancer. We need to do it. If we don't do it, we'll be, I don't know, I'm not trying to write off M1. M1, you cannot do it alone. You can only do 1 or 2 people. And there are thousands of Nigerians suffering from cancer. Yes, what you're doing is helpful. What Brecken is doing is helpful. What Medicaid is doing is helpful. But let government live up to its responsibility. We, the community of advocates, the professional bodies, M1, NMA, name it, we need to form this strong community of advocates and push for government to fund cancer. Through that process, we can go a long way. Not also forgetting that individuals can also play their bit, corporate bodies can also play their bit. So having said all that, I want to quickly appreciate the doctor from, or the prof from Jute Jos. I learned a lot from your presentation. You can see everything boils down to funding. Everything boils down to funding. And I had a heart attack when you said your coverage was 0.01%. That's just a blessing. In Nigeria, in the whole Nigeria, I don't know. It's disheartening. We need to figure out how we can improve on screening to our people. And there are quite other challenges he mentioned, like this out of pocket. We can encourage our women. Let us start with our women. Encourage them to have a culture for health insurance. The beauty of First Ladies is that we command thousands, if not millions of women in our respective states. And that had made it possible to bring them closer to us. And once they see our heart, they see our sincerity of purpose, and we encourage them to start saving. Even if you don't fall sick, the mammogram is not meant for a sick woman. Mammogram is meant for a healthy woman. You just want to know the status of your breast. The same thing goes for normal screening for cervical cancer. So even if they don't have any major ailment that they will spend that money for, you use it for screening. We need to encourage them. Save 1,000 or 2,000 as the case may be. On a yearly basis, during Breast Cancer Awareness Month, all the ladies will dress up in their pink. They have their mammo check. They can also do their cervical cancer screening check. When they continue doing this year in, year out, apart from saving for themselves, they begin to save for other members of the family. Health insurance is zero. Nobody even wants to touch it. Nobody seems to be interested because we have not promoted it. We have not presented it on a plate that people will be happy. It's like you're serving them a meal. If you present it nicely, they want to touch it, they want to eat it. That's the angle I'm also looking at. When I look at all the women, my women around me, I say you can encourage these women to start saving. And we'll make sure that whoever handles this health insurance is somebody that will not be telling them stories or later on. So with this, I rest my case and I appreciate for being here. Thank you all.
Thank you very much, Ma. Your Excellency, First Lady of Ondo State, your passion is palpable. We thank you so much, Ma. I would like to call on now the next person who would give them the goodwill message, the President of African Organization for Research and Training in Cancer Aortic, Dr. Bello Abubakar. You're welcome, sir. The floor is yours, sir, for your goodwill messages.
Thank you so much. Can you hear me?
Yes, we can't hear you, sir.
Thank you so much.
You're welcome, sir.
Sorry, I am running my clinic today, but let me stand on existing protocols to say a wonderful job from all the participants, especially those that organized this, especially Dr. Ishaq Lawal, who is also an IOTIC member, and of course the chairman of this occasion, Professor Isaac Adewale, former Minister of Health and also a former president of IOTIC. The strategy for the elimination of cervical cancer is apt, and I think we should take every advantage of this momentum, considering the fact that the Millennium Development Goal was literally and unfortunately not realized. So to assume that it's going to be an easy task to have the 90-70-90 is indeed something that we really have to put all our efforts in this country. I do know that training is very critical. We do not have the technical know-how and the manpower to cover 200 million people. And it is now that we really need to start all those things. And equipment are critical. And the Ministry of Health, I know they are listening, must take the clinicians and the care providers anytime they want to procure equipment. It is indeed disheartening that we have almost 10 brachytherapy equipment that have been lying fallow in the last 1 year without being put to use for one technical reason or the other. So if I want to believe that if the Ministry of Health has taken everybody along ab initio, we will not be in this situation. The other thing that the First Lady and the founder of BRECAN has mentioned is funding. And that is very critical in the sense that government cannot do it alone. We must involve the private sector. We must involve the banks. The African Development Bank is positioned to support countries like Nigeria. They have already supported countries like Bangladesh and Myanmar with soft loans. And I think this is a very critical moment for us to access those kind of funds. I know that the National Health Insurance has already incorporated radiation therapy treatment as part of their benefits, but it's only covering 1.5% of the population. And for that reason, it is almost impossible to achieve 90-70-90 without funding. So I wish you well, and IOTIC is always here to support any endeavor from any country, especially Nigeria, where we have the highest number of members. So we will be here to support any endeavor in terms of training, in terms of research. And I hope that after this webinar, we can put our heads together and see how we can provide templates and guidelines for the actualization of the 90-70-90. I thank you once again for giving us this opportunity, and I wish you well.
Thank you so much, Dr. Bello, for your goodwill messages. We appreciate your participation and your time, sir. Thank you very much, sir. We'll be calling now on the President of the Nigerian Cancer Society, Dr. Adamu Yuma, for your goodwill messages, sir.
Thank you very much. Hello, can you hear me?
Yes, we can hear you, sir. The floor is yours, sir. You're welcome,
Thank you
sir.
very much. The chairman of the occasion, immediate past Honorable Minister of Health, Professor Isaac Folorenshaw Adewale. Glad to see you and to hear from you again, sir. Permit me to quickly recognize few individuals among the distinguished personalities in this meeting room today. First is a past president of the Nigerian Cancer Society, Professor Ekanem. I want to also acknowledge the presence of the patroness of the Nigerian Cancer Society, Her Excellency, Mrs. Betty Anyawa Kredolu, founder and CEO of Breaker, one of our major benefactors in the NCS. Her Excellency, the board member of Union for International Cancer Control, the First Lady of Kebbi State, founder, CEO of Medicaid, the IOTIC president, my teacher, Dr. Abubakar Bello, GOSON president, Professor Bala Muhammad Audu, the president of the Commonwealth Medical Association and the past president of the NMA, Dr. Osahon Enabulele, M1 president, distinguished personalities. It is a very huge honor for the Nigerian Cancer Society to be part of this very august gathering here today. And I am personally elated, going by the energy displayed over the past few weeks in the build-up to this very important occasion. I was privileged to watch the launching of the global strategy by WHO yesterday. And it was truly, truly fascinating watching the videos from all over the world by women affected by cervical cancer coming out to speak and coming out to encourage others. For the first time, over 194 countries all over the globe came together to form a synergy towards accelerating the elimination of cervical cancer. It is actually doable, considering the fact that cervical cancer is preventable in the first place. Secondly, cervical cancer is treatable when detected early. And it is still alarming to know that cervical cancer is the fourth commonest cancer in women. So that is the reason why I'm very happy and elated to be here. And I'm glad the participation today has been quite impressive. I noticed from the very word go, from the moment we started this meeting with over 80 participants. We hit 100 and we surpassed 100. And this is one of the few meetings I have attended that you don't notice participants going out and coming back into the room. It goes to show that the quality of presentations, the quality of comments coming from stakeholders here today is truly quite impressive. And I am still running clinic, but I had to put everything aside in order to pay very close attention to everything that is happening here. I must salute Professor Daru. I must salute the M1 president. I must salute the diasporian presenter that presented on CAN screen. And I must equally salute my teacher. he calls me my friend, I call him my teacher, because I worked under him at the University of Abuja Teaching Hospital way back around 2004, 2005, Dr. Ishaq Lawal. The energy displayed by Dr. Ishaq Lawal and the collaboration of all these NGOs has truly shown us something. It has shown us the way All those that spoke earlier highlighted the fact that we cannot do it alone. We need to synergize, we need to collaborate, we need to come together in order to provide a very solid policy foundation so that everything we need can come. Because as rightly stated by Her Excellency, the First Lady of Ondo State, if we can come together, if we can work together, we are definitely going to be like tsunami because no force can stop us. And it has gone to show that everybody will listen to us. Governments will listen to us. The ministry will listen to us. The world will listen to us. So sincerely speaking, I must celebrate all of you. I have been on the sidelines monitoring the coordination, the efforts put in, the sleepless nights. Sometimes I wake up around 5 a.m. to pray and I see messages sent around 2, 3, meaning that people that make this event possible were not sleeping over the past 3, 4 weeks. I must salute you for that. It was quite impressive. Yesterday, the lighting of monuments across the country has gone to show that Nigeria is truly ready. And together, we are going to conquer. And together, we are going to make a difference. In one of the slides highlighted by Dr. Ishak earlier, I was so impressed to note the event, the only event as at 2016, a companion event after the official launching by WHO. That is a significant signature. That is a significant milestone. And we should all leverage on that and make sure that we ensure that we achieve our targets. We ensure that we achieve our goals. We have people that matters. I went through the list of participants and sincerely speaking, I'm very impressive. Most of my new executive members of the Nigerian Cancer Society are here. A lot of our NMA people are here, probably because the M1 president has done very well in making sure that this activity is publicized, because I have been witnessing her post on the NMA NEC group, and a lot of them are here, state executives of NMA, M1 chapter presidents, M1 executives, and it is a call, it is a clarion call. The Honorable Minister of Health, in his opening remarks as chairman of this occasion, said something. He said, in Nigeria, whatever we are determined to do, we get it done. And I think this is the time that we answer this clarion call and make sure that we don't disappoint the chairman of this occasion. Let's come together, let's collaborate together, let us solidify our front and make things happen. I'm glad to be here, and I wish us the very best. And I hope the next steps that will emanate from this very important gathering will go a long way in ensuring that we achieve our targets. Thank you so much.
Thank you very much, sir. Dr. Adam Ihuman, National President of Nigerian Cancer Society. We appreciate your goodwill messages, sir. We'll be calling now on Professor Bala Haudu, the President of Gynae Oncologic Society of Nigeria. You're welcome, sir. We're ready for your goodwill messages. Professor Bala Haudu, sir.
My mentor, can you hear me?
Yes, we can hear you, sir. You're welcome, sir.
Mr. Chairman, sir, my mentor, Professor Adewale, the team that brought this meeting together, led by Dr. Isaac Lawal, a very passionate cancer advocate and a member of the Gynecological Oncology Society of Nigeria. Thank you for this opportunity to deliver a goodwill message to this meeting. The energy that has gone on to make this meeting the success it already is a testimony that we can actually achieve the WHO strategy for the elimination of cervical cancer by the year 2030. However, we need to put in a lot more effort, collaboration, and cooperation, particularly federal and state ministries of health, to ensure the implementation of the strategic plan for cervical cancer prevention and control in Nigeria, which the document is for 2015 to 2021. It is very pertinent that all efforts are made to implement that strategic plan. If we look at the 90-70-90 strategy, the first 90 to achieve 90% in Nigeria is undoubtedly a great challenge, particularly when it is obvious that HPV vaccination in Nigeria is only available in very, very few private outlets, and it's very expensive, coupled with the fact that availability of vaccine worldwide is also challenging. It requires government effort at the federal level to ensure that Nigeria gets the vaccine available. And then we have to work with it of vaccine screening prevention. Still also represents a Herculean challenge. I'm sure Professor Daru was asked to make his presentation because the University of Just Teaching Hospital is one of the institutions in this country that has one of the largest, definitely the largest screening data in this country. And you can see, in spite of all the great efforts they have put in place, they have only 100th of a percentage coverage. This represents the nature of challenge we are going to face, but it can be overcome. Of course, the third 90 of 90% gaining access to treatment to cervical cancer. The IOTIC president just spoke about the challenges of radiotherapy in this country, the challenges with the equipment, their availability, cost, and so on and so forth. Skill for surgery, even when cancer is identified, cervical cancer is identified early and treatable. So there is a Herculean challenge before us, but these are surmountable. I hope with the success of this meeting, we'll be able to mount the needed advocacy to ensure that we are able to walk the talk, which is often the bane of our challenge in this country. Good ideas, good policies, but the greatest challenge is implementation. Let this meeting metamorphose into a force that would enable us to implement the ideas we have put together. Thank you and best wishes.
Thank you, sir. Professor Bala Haudu, for your goodwill messages. We appreciate it, sir. Our next goodwill message will be from a representative from UICC, Union for International Cancer Control. She sent a slide for goodwill messages, so we just show that now.
global commitment, international action. This is the prize expressed in lives saved. Let's take a look at this global strategy. I ask you to be inspired by the WHO vision for a world free of cervical cancer. I urge you to stay focused on the 2030 coverage target, 90, 70, 90, as it is these that will put all countries on the pathway to elimination. And I challenge you to create the enabling environment for women and communities of Nigeria to shape and be part of realizing this goal. The clock to 2030 is ticking, and our immediate focus is translating global commitment into national action. This is the prize expressed in lives saved. With concerted action, 15 million women's lives will be saved by 2030. With concerted action, 3 urgent steps. 1. Can we urge your government to make a public commitment? I therefore recommend 3 urgent steps. 2. Can we press your government to work with WHO to model elimination in Nigeria? 2. This will be a galvanizing timeline of action. I include some examples here. 2030 for Australia, 2040 for Canada, and 2070 for China. And 3, can we encourage early update of the Nigerian National Cancer Control Plan and a dedicated strategy to cervical cancer elimination with this new timeline in mind? I will take this opportunity to stress how critical it is to work across all 3 prongs of the global strategy. Recent investments establishing a network of 8 cancer centres across Nigeria is an excellent focus for ensuring referral mechanisms work well for early detection, diagnosis and treatment of cervical cancer, but also for palliative care. Linking screening programs into these networks will be key in ensuring follow-up of all women with positive findings from screening. Success here will encourage more women to embrace the prevention potential of screening. And it is impactful screening programs which will drive the early mortality reductions, but further mobilize engagement and community demand. I know securing HPV vaccine is a challenge for Nigeria. I offer UICC's links to both World Health Organization and Gavi to facilitate renewed talks and planning in this respect. Ensuring girls of the highest risk are protected through HPV vaccination must be a priority for the global health community as well as Nigeria. We'll take this opportunity. Moving to my summary slide, civil society in Nigeria, and especially Kebbi State, is joining forces to galvanize action and support policymakers in next steps. Now the challenge is to bring in more stakeholders from the NCD community, from the fields of HIV and sexual reproductive health, religious and community stakeholders that can help with the geographical reach message to all communities in Nigeria. As you start your planning today, please also think about who is missing around this table and needs to be invited next time. Particularly, let's think of you, as it is young people of today that will take us over from us and make cervical cancer elimination in Nigeria a reality. I wish you every success with discussions today. Let's get to work. I thank you for your attention.
Thank you. Thank you all for all the goodwill messages sent. We appreciate it. We are pressed for time. We wouldn't have enough time to take the remaining goodwill messages, but we appreciate everybody's contribution and participation. You can see even people raising up their hands. Prof, so with your permission, Chairman, I would like to just ask that if we could just take a question from Mr. Olajide Akeredolu. His hands have been up, his contribution since I think the beginning of this event.
Yes.
So can I go ahead? He has to give him 2 minutes to just.
I think we can just take from 2 of them and then we can then round up.
Okay,
thank you, sir.
Yes, thank you, sir. Mr. Olajide Akeredolu, please go ahead. The floor is yours.
Okay.
Your contribution, sir, please, you have 2 minutes, sir. Thank you, sir.
Okay, yes, I'll try to be quick. My name is Dr. Jide Akeredolu. I'm actually the immediate past district governor of Rotary International. And I wanted to highlight that Rotary has actually started a program for free immunization of young girls against the HPV virus. We actually started last year. We are covering Lagos and Ogun State. And what we did was in conjunction with the Lagos State government and the Ogun State government, we've been going to selected public schools. We decided to choose public schools because we think those who go to private school probably could be able to afford it on their own. And since our program is supposed to be free, we've been going to public schools, and we arranged with the principal. We have a PTA meeting with the parents, and where we do a lot of advocacy, and we explain to them the purpose of what our program is all about. And we now get them to sign consent forms. And when they sign, we now come in a week later as a team and vaccinate all the children. We were targeting kids between the ages of 9 and 14. And so that is what Rotary has been doing. So we've been on the field for quite a while, and we're quite happy that the WHO is now taking it up to do it in a global fashion. Rotary International, our headquarters, have just actually given us a grant of $126,000 for us to expand our program. And we're going to go to more schools in Lagos and Ogun State to actually do the vaccination for them. We are at present emphasizing on the primary vaccination. That means that is what we call the primary prevention. I can see nobody has actually emphasized that the limitations of screening. We know when you have to have screening has a time limit. You need to repeat it on and on, every 3 years or so, for it to be quite useful to the person you are screening. If you screen somebody 5 years ago, I could actually be having cancer now as we speak. And if you don't continue to screen that person, you will not be actually achieving the purpose of eliminating cervical cancer. Our program is actually school-based. It's not community-based because we identify that we have a captive audience. We go after the children in the GSS schools, and we vaccinate them and give them a certificate, which they will actually take to show that they've been completely immunized against cervical cancer. And that is what we hope, the templates that we hope to use to expand our activities. It's actually quite easy, and it's something that I think the governments can also do. It's something we can link up to immunizing the children in their schools. And just like we do with the birth registry or the having your immunization card, we can also have, maybe because before you go between GSS school to SS school, you must have your HPV vaccination card. And in that way, we can actually increase the vaccination rate. It's quite a cumbersome program because of its cost. We've been able to have a relationship now with GSK, which is the producer of Cervical, one of the 2 vaccines that is actually in there. And they actually supply us a steady amount of vaccines. And we also have a private company that actually does the real vaccination with them. And we coordinate this with the state ministries in Lagos and in Abeokuta. That is what we've been doing.
Thank you so much, sir.
And I thank you very much for allowing me to.
Thank you, sir. Yes, sir.
What we've been doing.
Thank you so much, sir. We appreciate your contribution, sir. We'll call quickly on Mr. Okai Aruna. He has his hands raised also, and please, Mr. Okai Aruna, you can speak with us.
Thank you very much for giving me the opportunity. I want to stand on. We actually have implemented cervical cancer screening. In fact, we also implemented primary prevention. At the point we're giving the vaccination, but because of the cost, we couldn't continue. So, but we did the screening. This particular project was implemented from 2012 to 2016 when Dr. Ramoto Hassan was the DEX officer. And I'd like to say that after the national launch, we're actually sharing data with the Federal Ministry of Health. And at every point that we're developing all those strategies, when Prof was minister, EPFL actually participated, and we strategy, the guidelines of cervical cancer. So in a nutshell, I said the 1970-90 global strategy is achievable if we can work together. I appreciate the passionate talk from the First Lady of Ondo State. Of course, funding is a major issue, but that if we can all put hands together from individual, from NGO, and with the government, we can actually achieve this global strategic elimination for cervical cancer. Thank you very much.
Sir, thank you so much for everyone's participation and contribution. We move on to the next item for today.
Thank you very much for the good messages, everyone. Briefly, because we are coming to the close of this meeting in the next few minutes, I will just call on the representative of the coalition of the NGOs that are involved in this program, Dr. Salako and Dr. Oluwashola, to actually speak, please. Thank you.
Thank you very much. I'm Dr. Oluwashola. I think if Omolola is on, she will make a comment on behalf of the NGOs. I am a stakeholder because I'm a gynecologist and I manage patients who have cervical cancer. But like has been said by all presenters, what is important is for us to prevent cervical cancer, and this is doable. We'll continue to collaborate with everyone and ensure that we eliminate cervical cancer. There are so many NGOs that are working on elimination of cervical cancer. We just heard from Rotary International and from PPFN. What we need to do is to bring all our efforts together, ensure that all of us are on the same page, and ensure that we follow the same protocol. If we have a central data that is able to provide additional information at every point in time, and we have like a graph to show how far we have gone. For example, somebody's just asking how many girls have been vaccinated so far. If you have this information, it's going to help to be able to put facts and figures down on how far we have gone. Secondly, on the idea of vaccinating, especially secondary school girls, this has been a burden that many of us have been talking about because it's an easier way out to prevent cervical cancer. The ones that are on ground, we can't finish managing them several years to come. But if you can prevent additional infection with HPV, additional occurrence of cervical cancer, then come 2030, we would have achieved a lot. Once again, thank you very much. Have a beautiful day. Thank you, Samuel.
Thank you, sir, for that. Do we have Dr. Salako, please? Dr. Salako? Okay. If not, we'll just go to the vote of thanks now, as we call on Ms. Tewa.
Sorry, we'll have chairman's closing remarks first before we go to vote of thanks. Professor Adewale.
Well, thank you so much for looking, except that is not on the agenda. But I will say a few words to appreciate the organizers for taking what I would consider to be a big jump forward in the battle to eliminate cervical cancer in Nigeria. And to thank the MCs for the efficient way and manner in which you have coordinated the presentations. I think what is critical is where do we go from here? We've had series of this type of presentation. I think what we now need to do is to work together with Dr. Lawal, continue with his team to coordinate various efforts. So many things are happening all over the country. I think we need to now pull our resources together. Let us work together. And when we work together, we'll achieve more. And this battle is winnable. So I want to thank you all. Let's move forward. I'm particularly excited as to what PPFN is doing. I will get in touch with PPFN after this meeting. I sit on the board of IPPF, and I will definitely support the initiative and for PPFN to get more involved in Nigeria, particularly adding vaccination to screening. And I think we can go places. Thank you once again for our excellencies. I will want to implore Dr. Lawal will do a letter to both of them. Let us start with Kebbi and Ondo State. Let us have a budget line item for cancer. I think we can start from somewhere. And when we start from those two states, then we can approach the governor's secretariat so that we can have more states joining. Thank you once again, and I say congratulations for this noble effort. The sky is not our limit, but the beginning. Congratulations.
Thank you very much, sir. We appreciate you, sir, for your great leadership. We thank you, sir. So we'd like to call on Dr. Tewa Nosaya for the vote of thanks. The floor is yours, ma'am.
Good afternoon, ladies and gentlemen, excellencies. I'm going to stand on all protocols. First of all, I'm not a doctor. I'm a pharmacologist by training and a philanthropist. Hence, I founded the Exquisite Magazine Cancer Care Foundation, which has been vaccinating and screening women. Well, we've been screening women free for cervical cancer since 2010, and we started the Vaccinate Her campaign in 2017 to vaccinate children. So I'm glad that this has come up in terms of the elimination of cervical cancer in Nigeria, and we are all on the right path. So I want to say a big thank you to every single person that has joined us today. We've talked about the commendable effort that Nigeria is being put on the map to eliminate cervical cancer through vaccination. We've talked about collaboration being very important for the vaccination services to be rendered across Nigeria. We talked about the need for awareness and ways to reduce cervical cancer deaths, cervical cancer-related deaths in Nigeria by HPV screening, vaccination, and we also spoke about the need for data collection. Essential data collection is important. So we called on health centers to be to have screening women for cervical cancer and breast cancer as a norm, as what they would be doing usually, so as to be able to meet this 9/7 target. We also spoke about the call on the government to fund NGOs and fund different initiatives to help reduce the cause and eliminate cervical cancer. At the end of it, we spoke about collaboration being really key, which is why the coalition of NGO was formed. And thank you, Dr. Ishak, for the job well done. I'm going to say a huge thank you and congratulations to everybody that has attended this webinar or this Zoom call. I'm going to say a big thank you to the First Lady of Kirby State, Dr. ZSB, Her Excellency. I'm going to say a big thank you to Her Excellency, Mrs. Betty Anyanwo Akeredolu. I'm going to say a big thank you to Professor Daru, to Dr. Andrew Cavello, to Dr. Sheson Oluwashola, Dr. Ishak, I mentioned earlier, to Dr. Atuwa from the Federal Ministry of Health, for the President of the Nigerian Cancer Society, to Dr. Bala, Dr. Ekanem. If I've missed anyone out, you are appreciated, and we thank you for taking the time out to join us today. Together, we can all win. And this has been shown with the efforts yesterday from all the different NGOs and all the different state governments that joined the WHO to light up the country. I say a massive thank you, and we appreciate you. Till next time, my name is Tewa Onosonya.
Thank you so much. Thank you, Tewa. Thank you so much for being part of this epic and historic event. We're delighted and happy and glad that you all could join and be part of this. We believe that we would go from here and take action. My name is Dr. Folike Sarimiye, a radiation and clinical oncologist and the co-founder of Patella Care Foundation. I've been moderating with Dr. Samuel Kodayo, is the founder of Dave Evans Foundation. We thank you all for your patience, for your attention, and your participation. So to bring this lovely and important meeting to an end, let's all rise up where we are and take the second stanza of the national anthem, and from there we can go. Have a wonderful week. Thank you all.
Are you hearing?
I'm here now.
I'm not hearing. I think I have problem. Put on your mic.
Thank you.
Thank you.
So, thank you.
Yeah, well done.
Thank you, sir.
Can we have group pictures?
Okay, and someone said, can we have pictures?
Yeah, we can all put on our videos.
Okay. Let's call Prof.
Yeah, Prof has done.
Okay.
Well, taking some
pictures, snaps. Okay, we can have one again.
Okay.
So nice to see everyone.
Thank you.
Professor Shama Suzu, we appreciate you, ma.
Gentlemen, thank you very much. It's been wonderful.
Okay, I'm going to allow everybody to be on mute now.
Thank you, everyone.
Thank you.
Thank you, sir.
Thank you.
It's a privilege to be a part of this.
Yeah, it's great having everybody on.
Thank you. Dr. Ishak Lawal,
Professor
kudos to you, sir.
thank you, ma.
Dr. Ishak.
Congratulations to all of you.
Dr. Ishak.
Malga.
You are doing well. You are doing well.
Our president.
You are doing well, sir. You are doing well.
Dr. Adike, Dr. Loring, Dr. Fidatuo, we appreciate you all. Dr. Olude, thank you, sir.
Well, I'm sure this is just the beginning. We'll be reaching out for more collaboration. Thank you very much.
Adebola Moshe, how you doing? I used to know you as Adebola Ebo. Thank you, the NCS president, sir.
Dr. Thank you very much. Until I come. Until I come, sir.
Nice to see you.
Thank you, sir.
Yeah.
Dr. Luwashola, thanks for giving us the platform.
You're welcome, bro. I appreciate your great efforts.
We are taking after you.
Dr. Fifian Omar Goja, thank you for joining us. Prof was with us in lighting up of usage yesterday, all the way from Delta State.
Wow. Wonderful.
I saw Dr. Bisoyo Yemi at a point from Bayelsa. His wife is a gynecologist, he's a public health physician. Sure, it's been a great meeting. So thank you, everyone.
Thank you.
Okay, I think we can end the meeting for everyone. Dr. Luwashola. We can't hear you. You are muted, Dr. Shola.
But you can hear me.
I can hear you now. Dr. Foluke, well done. We enjoy your full name.
Thank you, sir. Thank you.
Dr. Lawa. Thank you for the opportunity given to us.
Yes, I have.
Thank you. I'm glad to be part of this meeting.